All right, in part two of the elbow pathologies, we're going to start with the radial collateral ligament sprains. Overall, these are relatively rare. If you're going to sprain something in your elbow, it's going to be your UCL, not your RCL. Um, and it's rare because, first, there's so much motion within the arm. It's really hard. You're not oftentimes having your hand stabilized on something. And your body's going to act to shield against that varus force, because a varus force is from the inside out. The force comes from the inside and it ends up stretching the structures on the lateral side, which is where your RCL is. So it's not overly common to have an RCL sprain. But if we do damage it, it could result in laxity because it is connected to it is the primary stabilizing structure on the lateral side of the elbow, and it's also what holds the radial head up against the capitulum. So those two have to be together for us to have flexion, extension, and supination, pronation. So if those aren't connected anymore, there's going to be some laxity. So the overall MOI is going to be varus force, a medial force in some way, stressing or pulling apart those lateral structures. Just like with the UCL, you're going to have pain with motion. In this case, we're not only have flexion and possible extension, but also have pain with supination and pronation because the radial head does supination and pronation. Point tenderness over the lateral elbow, over that lateral epicondyle where the RCL actually is, probably swelling in the area, and you may have some pain or problems with the annular ligament because the RCL actually inserts into the annular ligament. Remember that it runs from the lateral epicondyle and inserts to the annular ligament. You will probably see some reduced range of motion as a result of pain, especially, again, that supination and pronation. That's how you'll know the radial head and the RCL are going to be involved because that's the area where supination and pronation occur. Pretty easy to diagnose. I mean, you're going to have an obvious varus force. It's not going to be an overuse injury, so it's going to be a traumatic problem. Varus force, pain with supination and pronation, point tenderness over the lateral epicondyle / radial head, and then a positive varus stress test. And again, remember, for a varus stress test, we're looking for not only pain in that area, but also how much laxity is going to be involved, because that's going to give you your grade of how severe the problem is. But pretty straightforward when it comes to an injury. Nursemaid's elbow is an actual radial head subluxation. This is most common in children. Whenever there is a sudden traction force, a sudden pulling force, so when you actually grab a kid's hand or arm and pull very forcefully, it can actually pull the radial head out of that annular ligament. Remember, the annular ligament acts as a sling and holds the radial head in place. The fibers are not connected, but it is wound pretty tautly around there, so it's supposed to stay in place. So whether it's from child abuse or actually it's often seen when you're playing around with a kid and you're swinging them or pulling them in a fun, playful manner, but it's still a very strong force. If they're not ready for it, then you can actually see this dislocation of the radial head. It may or may not be overly painful. Children are way more lax than adults are, so it could pop out, really not cause that much pain, but it will obviously end up resulting in decreased supination and pronation, as well as flexion and extension. So there's probably going to be some pain there. They're probably going to be scared. The elbow or the forearm is not going to be able to supinate and pronate, so it is going to have to be reduced. It is generally reduced or put back in place if you're able to supinate the forearm while the elbow is flexed. So if you want to try that at home as a parent or whatever, go for it. So again, it may or may not be overly painful, but this is a specific kind of subluxations where the radial head is subluxed away from the capitulum. It's pulled out of the annular ligament as a result of a sudden traction force. Again, most common in children. All right, so now to our overuse injuries. Lateral epicondylitis. This first slide here is kind of I have an anatomy side note. There is 3 structures: the brachioradialis, the extensor carpi radialis longus, and the extensor carpi radialis brevis are going to be called the mobile wad of 3. It's also been called the mobile wad of Henry. I don't know why. They're grouped together because they're actually all surrounded in a group of fascia. So just like in the low leg, in the forearm we have all these different muscles, but then different muscles are actually kind of grouped together, and then they're surrounded in their own compartment, and they have their own fascia surrounding them. So this is one of those compartments. It's also known as the lateral compartment. So these 3 muscles are in their own compartment, and all three muscles are not only going to possibly help with the wrist, but they're also going to help with elbow flexion. So in this picture up here, the brachioradialis is not in this picture, but if you remember, the brachioradialis is going to start on the supracondylar ridge, the lateral supracondylar ridge. So it's going to start right here, and it's also going to move down the forearm, and it's going to end up following the path of the extensor carpi radialis longus and the extensor carpi radialis brevis. So these three muscles are going to all start in the same area. The brachioradialis is going to start higher, then your extensor carpi radialis longus, and then the brevis. They're going to run together down the forearm. The brachioradialis does not affect the wrist, where these two muscles will affect the wrist, but just in case you come across this on the BOC or you hear a physician talk about it, I remember I was quizzed by Dr. Bilbo about this when I was a student. Just be familiar that these three muscles together are called the mobile wada 3. They're in their own compartment, and they're going to help with elbow flexion. Now back to lateral epicondylitis. This is also called tennis elbow. What we have here are 5 muscles that are going to all have a common origin. They're all going to start in the same place, and that's going to be the lateral epicondyle. So our extensor carpi ulnaris, extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, and your supinator are all going to have this common origin here on the lateral epicondyle. So that's a lot of force coming from these 5 muscles when they contract, all having force applied at one area. It's not spread out, it's all over that lateral epicondyle. So it's going to be susceptible to high amounts of force. That means susceptible to injury. So to get to the lateral epicondylitis, generally you get it from repeated forceful eccentric contraction of the wrist extensors. I talked about this a little bit in class last week. It could be from repeated concentric extension of the wrist, but we see it more often in athletics from repeated eccentric contraction of the wrist extensors. This is an insidious onset, so it's a chronic condition. We don't exactly know why it started or how exactly it started. It just develops over time. But in tennis, this is very common because of the backhand. So as the ball comes in, you're ready to hit this backhand. Your wrist is basically locked in this position, but depending on how fast this ball is coming and the weight of your racket, as the ball hits the racket, your wrist is going to give a little bit, and it's going to be forced into some wrist flexion, which is an eccentric contraction of the wrist extensors. So it's not that he's actually bringing his wrist back and doing full concentric wrist extension. It's that he's trying to prevent wrist flexion. And when the ball hits the racket, it still goes into wrist flexion, and because he's trying to resist that with wrist extension. That's the eccentric contraction of the wrist extensors. Pretty easy to diagnose. You have pain over the lateral epicondyle. So very point tender pain right at the lateral epicondyle, and then when those muscles are contracting, they hurt. So when those 5 wrist extensor muscles with the common origin, when they contract, they're going to cause pain. You can also have decreased grip strength and possible swelling in the area. And then the special test is the lateral epicondylitis or tennis elbow test. But basically, that is just resisted wrist extension while palpating the lateral epicondyle. Now, don't forget that this is an elbow problem because these structures originate at the elbow. But flexion and extension really are not going to hurt if you have lateral epicondylitis. In order to actually diagnose this, you're going to have to do wrist range of motion and really not elbow range of motion. So either you're going to do both or focus on the wrist, because you're not going to get a lot of information by doing range of motion at the elbow. You're going to have to do it at the wrist. So here's some more pictures. When you look at the force that's involved, I mean, obviously these are professionals, but the ball is very flattened here. That means it's coming at a very high rate. So when this ball hits this racket, she's in full extension. She is relying on relatively weak and small muscles to prevent the tennis racket and ball from moving into flexion. So that's a lot of force at the wrist to keep this position locked when the ball is coming at you. I mean, there's a ton of force involved here. So that's going to be one of the reasons. So even in high-level athletes, you see tennis elbow. Then when you think about it in lower level or more recreational athletes, this muscle group is very weak, and if you don't have the proper size racket, the proper weight racket, the proper technique, you're going to be even more susceptible. So very prevalent in about 50% of tennis players, in athletes over 40, especially in those racket sports that use backhand, just because of the amount of force required and the relatively weakness of those wrist extensor muscles. When it comes to treatment, stop doing what you're doing. You have to let it heal. You can use NSAIDs, modalities, rest. You could possibly get corticosteroid injections in the area. Definitely do your rehab with wrist stretching and strengthening of those elbow and wrist flexors and extensors. And then you can also use this thing called a tennis elbow strap, which is a generic term for a specific term for a counterforce brace. And you've probably seen these. People wear them on their elbows, and you will see them over the patellar tendon, so at the the proximal part of the tibia, over the patellar tendon. And what these counterforce braces are doing, really, they are just a strap with a pad, and that pad goes over the muscle group or tendon. So you're going to put this strap on. Here's the lateral epicondyle, so this is where the pain actually is up here. They're putting this strap a little bit proximally, and it's relatively tight. So in this picture, here's the pain where the purple arrow is. They're putting the counterforce brace on over the proximal part of the wrist extensors. So they're putting this strap on, and the whole point of this counterforce brace is to act as kind of a secondary insertion point. So when the brace isn't on there, and we contract our wrist extensors, all the force is going into this one insertion point. In this case, it's called the origin, whatever. When we contract, it's pulling, and all the force is pulling on this part of the bone. Well, if we put this counterforce strap on, when we contract now, some of the force is actually being taken up by this counterforce brace because it's acting as a second insertion point. So some of the force is going in here, and some of it's still going along the muscle, or the insertion point here. But if we're able to take away some of the force that's going into the bone, then we should have some pain relief. So wearing these straps basically gives you a secondary insertion point, and that whole point is to help take away some of the force, absorb some of the force, so it does not go into the actual, the real anatomical origin. And down here's the same thing. Here, number 2 here is where the counterforce brace would go, taking away some of the force that would go into this part normally. They seem to work pretty well. They're not going to fix the problem, but they're going to allow you to participate while you have pain. Unless you do all the other stuff and actually let it heal, the problem's going to continue. But if you are going to be participating and you are having pain, then this can actually help relieve some of your pain that you're having. Same idea now, but on the other side, medial epicondylitis. This is also called golfer's elbow. Same idea is going on here. We've talked about these 4 different muscles that all share an origin at the medial epicondyle. These are all our wrist flexors: the pronator teres, flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. They're all going to share that common origin at the medial epicondyle. Remember that they're also going to form the top of the cubital tunnel. And they're also going to help stabilize dynamically the medial elbow during the throwing motion. So this is a very important group. It's a relatively strong muscle group compared to the extensors anyway. But just like anything else, if they're overused, they can get that overuse injury. So the mechanism of injury is repeated forceful flexion with pronation of the wrist. This is, again, it's insidious onset. It's chronic. It's just going to develop due to overuse. But if you do that repeated and forceful flexion and pronation, you can end up irritating this area. This is common in golfers. I'm not 100% sure on how you're actually supposed to swing a golf club, but apparently they're susceptible to it because they do that flexion pronation motion. So just like any other chronic condition, pain with activity, it's going to feel better with rest, possible swelling, and obviously point tenderness over the medial epicondyle / pronator group. So again, very straightforward. But just like with the lateral epicondylitis, you're not going to see too much going on if you do elbow flexion extension. So medial epicondylitis doesn't really help the elbow whatsoever. So if you only do range of motion at the elbow, you're not going to get anything. You have to do range of motion at the wrist. There is the golfer's elbow test, and basically that just extends everything, putting tension on the medial epicondyle. But if you do the range of motion, you should find pain with active wrist flexion and passive wrist extension. Do be aware again that there's possible ulnar nerve neuropathy here, because if you have swelling in that area at the medial epicondyle where the wrist flexors originate, if there's swelling there because of a problem, it can end up putting pressure on the ulnar nerve. So now you got to deal with not only the ulnar nerve problems, but also with the medial epicondylitis. A little league elbow is common in children, especially baseball players. It is a problem with the growth plates at the medial epicondyle due to overpitching. So we've talked about how we can actually hurt our UCL, sprain our UCL during baseball pitching. Well, in this case, instead of actually tearing the UCL, we actually pull off part of the medial epicondyle at the growth plate. So normally in an adult grown baseball pitcher, that's going to be closed and they actually rupture their UCL. In a child who's overpitching and they're putting constant force on that UCL, they actually get an avulsion here at the growth plate of the medial epicondyle. So the wrist flexors actually pull off the medial epicondyle, causing that avulsion fracture. This kind of happens over time. One motion could end up actually causing the entire fracture, or it could just kind of be an irritation or a pulling the way. So there are grades to how severe this problem is. More of an irritation at the growth plate level, all the way up into the actual avulsion fracture. A lot of the signs and symptoms, especially if it's not fully avulsed, are going to mimic medial epicondylitis. But if you're dealing with this age group, though, and you think it's medial epicondylitis, I would still refer them. I'd still limit their pitching, slow them down, make them rest, make them stretch, make them strengthen, because this could be a major problem. So any kind of growth plate injury is very serious because they're still very young, which is one of the reasons why there are a lot of rules and regulations now, especially in Little League Baseball, and then high school and grade school and whatever, about how many pitches you're allowed to throw. So it is very important to educate people on what could possibly happen if you do throw too much. Another relatively common injury is the distal biceps tendon rupture. We're talking about the distal one because we're at the elbow, but this is going to be a rupture of the distal tendon that inserts into the radial tuberosity of the ulna, or of the radius, sorry. So when that thing ruptures, there's nothing holding down the bicep brachii anymore, so now you see this big giant bulge of muscle because it's only attached to the top and it's no longer attached at the bottom. So it's going to look very funny right above the elbow joint, because there isn't no bicep brachii anymore. So we are specifically looking at the brachialis in this picture because the bicep brachii is not there. Most common in males over 40 years old. That's who we tend to see in this population. They're just more susceptible. It can happen in normal athletics. It can happen a lot in weight training, or very, very heavy, heavy lifting. But what you see more is just the recreational male over 40 years old. 7.5 times greater in smoking or in smokers. Smokers tend to have more problems with tendons, makes them a little bit weaker. But what we're going to see here is eccentric loading of the bicep brachii when the elbow is flexed to 90. So you have, your recreational, male athlete who's out there and does whatever activity, and there's a forceful extension of the elbow. When you're at 90, if it's pushed down and trying to resist it, that's eccentric contraction, causing a rupture. If you are out and you're lifting really heavy things and you're not really used to it, lifting a box or sitting it back down and it's really heavy, that's going to be your eccentric contraction, again, causing that rupture to happen. Generally speaking, you're going to hear a pretty good pop because you just ruptured a very large tendon. Decreased strength with elbow flexion and supination because your bicep brachii does elbow flexion and supination. You'll probably have some decreased shoulder flexion strength as well. Obvious, a ton of ecchymosis and edema in the cubital fossa and a palpable defect. So when you do palpate in that cubital fossa, you will not feel the bicep brachii tendon. Because this is a very strong tendon, we often also see an avulsion fracture. So which is going to give first, the tendon itself or the bone where the insertion is? It could be either way. It could be either one. but there could be an avulsion fracture of the radial tuberosity that comes off. Instead of actually rupturing the tendon, we actually see an avulsion fracture. This is not going to heal itself, so if you do want to get this fixed, you will have to have surgical treatment. People who are not athletes oftentimes decide not to get their bicep tendon replaced. So besides the cosmetic problem where it looks kind of funny, functionally, yes, you're going to be a little bit weaker in elbow flexion and a little bit weaker in supination, but in the grand scheme of things, you still have your brachialis, you still have your brachioradialis, you still have a couple of those wrist extensors, the extensor carpi radialis, longus, and brevis, that are all going to help with elbow flexion. So you'll still have function, you're just not going to be overly strong. You're not going to be like ridiculously strong, but you're still able to get through daily life really without any kind of problems. So some people are saying, well, I don't want to get it fixed. I don't want to have, whenever you sew a tendon back together, the rehab is very long, so people opt to just not to do it. Osteochondritis dissecans of the capitulum. When we call this OCD, osteochondritis dissecans, there are several places in the body that are very common. The knee, the ankle, and the elbow. Those are the places that we see OCD. It could start off as just kind of a wear and tear of the cartilage around the capitulum, and then it could end up becoming the dissecans where there's actually a displaced body floating around in there. What we see here is, here's your drawn picture of an actual defect in the cartilage of the capitulum. So what we're looking at, here's the posterior side. So here's the olecranon, here's your radial head, and the humerus, this is a flexed elbow. So we actually see, so it would look like in flexion. Down here, we actually see a wearing away of the cartilage and actually the bone underneath as a result of compression of the radial head against the capitulum. So when we do a valgus force, the valgus force is from the outside in. So we talk about how with throwing injuries and UCL injuries, a valgus force from the outside in is causing compression on the lateral side and stretching on the medial side. So because it stretches the medial side, we're going to get a UCL sprain. But also with that throwing motion, you have a force from the outside in, that valgus force from the outside in. So it's moving this way. It's going to end up opening up the joint over here, resulting in our UCL sprain, but causing compression over the radial head and the capitulum. And that's how we get our osteochondritis dissecans. So gradual onset, repeated valgus forces that push together the radial head and the capitulum, and oftentimes there's also a decreased blood flow that it does not allow it to heal. So kind of a terrible situation altogether results in this OCD. Remember that anytime we have articular cartilage problems, it's a very severe problem. We do not want to damage our cartilage because it does not really grow back at all, and it ends up resulting in some sort of surgery, and the surgeries are not overly successful. When we see someone with this, they're going to have lateral elbow pain that increases with activity because we have that wear and tear. It could be a flexure contracture because if we have the flexure contracture, it actually keeps us in flexion. So a flexion contracture is basically not able to get full extension. Your muscles are so tight that they're not going to allow you to get full extension, and full extension is what is actually going to cause more compression here. So that's why your body will develop it over time, or you're just avoiding full extension, so your muscles end up shortening up. Sometimes you'll have just the wear and tear of the capitulum, where it just starts to expose underlying bone. Sometimes you'll actually have a loose body where a chunk of it came out and is now floating around in the area. If it is a non-displaced where there's no loose body, then it's more conservative treatment. If there is a loose body, then you'll have to get surgery to actually remove it and probably fix it. The good thing here, getting OCD in your elbow, unless you're a high-level athlete, shouldn't disrupt your life too much because it's not a weight-bearing joint. Where if you start to have wearing away of your cartilage at the knee or the ankle, even if you minimize your activity, you still have to weight bear on a daily basis. But if you minimize your activity with OCD and you stop that valgus force, that throwing motion, then you should be able to live relatively pain-free because it's not a weight-bearing joint. And then the last things here are our nerve trauma. Because the elbow does have the median nerve, the ulnar nerve, and the radial nerve, all those nerves are susceptible to problems. The ulnar nerve, remember your anatomy here, your ulnar nerve is going to sit on top of the ulnar collateral ligament and then is going to be covered up by the flexor tendons. So because of where they're at, the ulnar nerve itself might not be a problem, but because structures around it are irritated or inflamed or are stretched out or are not working correctly, all that can cause irritation and inflammation of the ulnar nerve, and because it's trapped underneath a tunnel or in the tunnel, then there's less space for it to go. So because we have a decreased space in that cubital tunnel, it'll end up resulting in compression of the nerve. So our signs and symptoms here, well, and that's called cubital tunnel syndrome. Sorry, I just added that one. Cubital tunnel syndrome. That's what that's actually called. And it is relatively common in overhead throwing athletes. Because of that irritation, we end up getting cubital tunnel syndrome, which is irritation of the nerve inside the tunnel. Because it's trapped, there's nowhere for that swelling to go, so you're going to end up getting these neurological symptoms. It's the exact same idea as carpal tunnel syndrome, where the median nerve is trapped in the wrist, which we'll talk about next chapter. But cubital tunnel syndrome is where the ulnar nerve is trapped. If it can be a chronic problem, and really the only way to alleviate it is to, in this case, we actually move the location of the ulnar nerve. We know the ulnar nerve is involved when we have burning, tingling, whatever, in the medial forearm and the little finger and the ring finger. So in this case, the blue here is the ulnar nerve distribution. The ulnar nerve is going to feed the pinky and ring finger. The other colors are going to be from different nerves. So in this case, you will definitely feel, even if you hit and move around your ulnar nerve, you can feel that that tingling and sensation goes into just your pinky and ring finger. It does not affect your other fingers. We're also going to see increased symptoms when the elbow is flexed. When the elbow is flexed, it puts more pressure and it actually stretches out the ulnar nerve. And we could also see decreased strength of the finger flexors and your thumb abductors, flexor carpi ulnaris. We'll go into that more next chapter, but those are the muscles that are actually innervated by the ulnar nerve. So if the ulnar nerve is not working correctly, it's going to affect the nerves that it actually innervates. And again, we'll memorize all those for the next chapter. And then claw hand. Claw hand is going to be a result of a ulnar nerve trauma where it's not working correctly, and basically its inability to make a fist. Your fingers are not going to be able to curl around. And again, we'll go into claw hand more next chapter as well. And then the last one here is our radial nerve. If you remember, our radial nerve is going to travel down. It's going to start on the back, and it's going to innervate the triceps and the anconeus, and then it's going to travel underneath the brachioradialis. So the brachioradialis is going to be sitting on top. So if we took the brachioradialis off, we're going to expose the radial nerve. The radial nerve right at the elbow is going to separate into the deep part and the superficial part. These two together are going to do both sensory and motor, mostly, sensory and motor of the wrist and forearm muscles. Not usually a problem unless we have some sort of very deep laceration or fracture, dislocation. So the radial nerve really isn't injured all that much unless there's some sort of big traumatic event. We don't see things like what we see with the ulnar nerve because the radial nerve is not entrapped in any kind of tunnel. It's just there. So if we do have, compression, the swelling has somewhere to go, unlike with the cubital tunnel. So if the deep radial nerve is involved, this one is purely motor and not sensory. So some of the muscles we already memorized are going to have that motor nerve for the deep radial nerve. The radial nerve is going to get most of the muscles for thumb extension, wrist extensors, and finger extensors, supinator, are all the deep radial nerves. So posterior forearm muscles, so all these together are going to be located on the posterior side. So it's going to get the posterior forearm muscles, where the superficial radial artery, the one that stays on top, is going to be primarily there for sensation. It's going to be the red, where its sensory function of the posterior arm, forearm, and the back of the hand is where we'll end up seeing the most distribution for the superficial radial nerve.